Hi guys, good evening. Good evening, good evening. Hi. Uh Good evening Liaquat, good evening Osama. Alright guys, so as we have started our trauma series since yesterday, तो आज हम trauma में continue करेंगे. So yesterday we spoke about the initial part of the trauma. That's how we do triage. What is the essence of the triage? How do you assess a patient? What is a primary survey? What is the goal of a secondary survey? In that we covered about the airway in the initial part. So today's objective is to cover rest of the primary survey that you have. We'll be starting with breathing and ventilation. Then go with the circulation and hemorrhage control. Then we go disability limitation and expose and examine. Okay. So without wasting any further time, let's kickstart the session for today. So we're talking about breathing and ventilation in terms of the assessment protocol. Now, in terms of breathing and ventilation, whenever a patient has been brought to trauma, how do you assess breathing? Now, the breathing assessment is done in three contexts. Number one, I'm going to look for the respiratory rate. That is going to tell me whether is there any respiratory distress is there or not. Number two, I will look for the chest wall movement. I look for the chest wall movement. And third, I would like to go ahead with auscultation. So to see whether the breath sounds are present or absent, right? So breathing assessment is done by predominantly three components: the respiratory rate, the chest wall movement, and auscultation. When it comes down to ventilation, the ventilation assessment is done with the help of saturation. We'll measure the saturation at room air, and thanks to COVID-19, we all know the normal saturation that is expected at a room air should be more than or equal to 94%. Anything less than that will be considered to be as a lower saturation, so you should be a bit more keen on this, right? So whenever a patient comes to you with trauma, when you're doing a breathing and ventilatory assessment, the breathing assessment is done with the help of three important components: the respiratory rate, the chest wall movement, and auscultation. So respiratory rate is normal around 12 to 16 cycles per minute. More than that can be called as tachypnea, and less than that will cause as the lower respiratory rate, which can also indicates a component of distress. If the chest wall movement is not happening, is there a restricted chest wall movement, or there's a paradoxical movement? Paradoxical movement of chest wall is seen in flail chest, right? Now all that will tell you about, is there any underlying component of pathology which is present. For example, in tension pneumothorax, as there is no air entry into the lungs or exit from the lungs, the chest wall movement will get restricted. Same component is there with the flail chest, where there will be a paradoxical movement. There will be an indrawing of the chest wall during inspiration. So chest wall movements do give you a hint towards the problem that the patient is facing. Auscultation will tell you about the air entries present, absent, diminished, and all that can be assessed at the same time. Saturation is going to tell you about the ventilation. So when you're looking at the breathing and ventilation, no, one of the most important things that you know, especially when you talk about breathing and ventilation, we are only talking not only talking about the lungs or the thoracic component, we're talking about thorax in general, right? So there's something called as the deadly dozen of the chest injuries, right? So what qualifies as deadly dozen of chest injuries? Now, in a deadly dozen, as the number dozen says 12, so there are 12 injuries which are going to be dangerous, which can occur in the chest. We divide the deadly dozen into two categories. One, we call it as immediate life threatening, another one is going to be potentially life threatening. So divide them into two categories. One, we'll be calling them as immediate life threatening. We call it as the immediate life threatening. Another one is going to be potentially life threatening. So in the deadly dozen, as it says, it is going to be associated with 12 injuries. It is a combination of 12 injuries. In that, 6 is going to be immediately life threatening, and 6 it is going to be potentially life threatening. Now, what are the injuries that qualify as an immediate life threatening injuries? Number one, it is going to be associated as the airway obstruction. It is the airway obstruction. tension pneumothorax, tension pneumothorax, open pneumothorax, tension pneumothorax, then you have open pneumothorax, pericardial tamponade, pericardial tamponade. So you have the airway obstruction, tension pneumothorax, open pneumothorax, pericardial tamponade, massive hemothorax. We'll talk about each one of them in detail. For now, you have to understand that these are listed as immediate life-threatening and the tracheobronchial injuries. Tracheobronchial injury and the tracheobronchial injury, right? So this qualifies as immediate life-threatening injuries. What are the potentially life-threatening injuries? In the potentially life-threatening injuries, number one, we have the flail chest. We have flail chest. We'll talk about the definition of flail chest as well. Aortic injuries. Aortic injury. Myocardial contusion. Myocardial contusion. Myocardial contusion. You have pulmonary contusion. We have pulmonary contusion. Diaphragmatic rupture. The diaphragmatic rupture, we call it as the diaphragmatic injury, and the esophageal injury. And the esophageal injury. So flail chest, the aortic injuries, myocardial contusions, the pulmonary contusion, diaphragmatic rupture, esophageal injuries, all these will qualify as deadly dozen. So 6 of them is immediately life-threatening, 6 of them is going to be potentially life-threatening. Our job is to identify the immediate life-threatening and address it as we move across. So this is in the context of breathing and its assessment status that we are going to follow. After you assess the breathing status, the next in the primary survey is going to be circulation with hemorrhagic control. So C is going to be circulation. It is circulation with hemorrhage control. Circulation with hemorrhage control, right? So whenever it comes down to the circulatory assessment, now this has been a very, very important component. And when you're looking at the assessment of the circulation, now the circulatory assessment, whether it is hemodynamically stable or unstable, can be assessed by, number one, by assessing the systolic blood pressure, and number two, it is going to be with the help of heart rate, or also called as the pulse rate. So 2 components that we will be taking into consideration. One is going to be systolic blood pressure, another one is going to be heart rate. Now remember, whenever the systolic blood pressure is less, heart rate is more, this indicates hemodynamic instability. This indicates hemodynamic instability. And in simple words, this hemodynamic instability is what we use a fancy word which is called as shock. Right. So whenever the systolic blood pressure drops and the heart rate picks up, we call it as the patient is hemodynamically unstable, or there's instability present, and which is basically determined as shock. Now, whenever this presence of hemorrhage, how do you control it? Now, remember the best way to control the external hemorrhage. The best way to control the external hemorrhage . So whenever it is going to happen, the best method to control external hemorrhage, it is to apply adequate pressure. It is to apply adequate external pressure. Adequate external pressure. So let's say a patient has landed up to the casualty where the patient is hemodynamically unstable, and then you see there's an external hemorrhage. Now you have compressed, or you applied the pressure on the external hemorrhage. Now, once you apply the pressure on the external hemorrhage, the patient can be hemodynamically stable or the patient may remain unstable. The patient may remain unstable. Now, if a patient is unstable, that indicates there is possibility of internal hemorrhage, right? So there is probability of internal hemorrhage. Now, my question to you is, what are the possible sites of internal hemorrhage, right? What are the possible sites where a patient can have an internal hemorrhage? Number one, it can be a thoracic injury or the thoracic hemorrhage. It could be your thoracic hemorrhage. It could be your abdominal hemorrhage. It could be the abdominal hemorrhage. It could be a pelvic hemorrhage. So the patient can bleed in the thorax, the patient can bleed in the abdomen, the patient can also bleed from the pelvic site. It could be associated with long bone fractures. Now, long bone fractures can also cause an extensive blood loss, right? So when there is an extensive blood loss due to a long bone fracture, that extensive fracture can cause an excessive amount of volume loss. That can result in excessive amount of volume loss, right? So looking at when the patient is unstable, the site where you have to look for, it could be a thoracic hemorrhage, it could be an abdominal hemorrhage, it could be a pelvic hemorrhage, or it could be your long bone fractures. Now the best thing is, whenever you're suspecting an internal hemorrhage, all these can be covered in a quick assessment tool which is called as FAST, which we'll talk in detail. FAST, or we call it as the extended fast, or we can say EFAST, right? EFAST is nothing but an extended fast. So what is an extended fast? An extended fast basically means extended focused assessment. It is focused assessment. It is the focused assessment with sonography, that is an ultrasound, in trauma. So whenever you have a patient who is hemodynamically unstable, especially after an episode of a blunt trauma abdomen, you can suspect that these are the sites. So if you do a fast, now you're covering thorax, you're covering the abdominal side, you're covering the pelvic side. So you will be able to localize the site of bleeding. So hence, this is what you have to look in the context of circulation with hemorrhagic control. So circulatory assessment is simply done by looking at the systolic blood pressure and the heart rate, which will give you an idea whether the patient is hemodynamically stable or unstable, right? Now, once we have a patient who is hemodynamically unstable, what is your approach? Let's say I have a patient who is having a hemodynamic instability. A patient is unstable. Hemodynamic unstable patient is there. How would you like to address this patient? Now, if you land up in a casualty where you have a patient who is hemodynamically unstable, in the context of hemodynamic instability, I can say the systolic blood pressure is less than 100 millimeters of mercury, and I can say the heart rate is more than 100 beats per minute. Now, this is what our Bailey says. But if you look at the ATLS, it says systolic blood pressure which is less than 110 millimeters of mercury. Subsequently, you have heart rate which is more than 110 beats per minute, right? The two data will stick to the data number one, where you have systolic blood pressure less than 100 and you have heart rate more than 100, indicating that it's post-trauma hemodynamic instability. Any patient who has presented to you to the casualty with these parameters and is suspecting hemodynamic instability, the first thing that you have to do, it is to secure two large IV cannulas. It is to secure two large IV cannula. Now, when you secure the IV cannula, you will be able to resuscitate the patient. Now, when you say two large IV cannulas, there's something that we should know. We should know the color code of the IV cannula. Based on the color code, we have the size of the IV cannula. Based upon the size, we have the flow rate, which is going to be per minute. Right? Now, the biggest one that you have is going to be orange colored cannula. So we have an orange colored cannula, which is going to be a 14 gauge needle with a flow rate of 240 ml per minute. That means if I secure an orange cannula, I will be able to push the fluid at 240 ml per minute. In simple context, half a liter of fluid can be given within 2 minutes. Half a liter can be given within 2 minutes. Okay? So we have orange colored cannula, 14 gauge. Okay? Then you have the gray colored cannula. Gray का size कितना है 16. How much is the flow rate? It is going to be 180 ml per minute. ग्रे के बाद कौन सा आता है? वी हैव ग्रीन कलर्ड कैनुला. ठीक है, ग्रीन का साइज कितना है 18 गेज एट अ फ्लो रेट ऑफ 90 ml पर मिनट. उसके बाद क्या आता है? वी हैव द पिंक कैनुला. पिंक का साइज इज गोइंग टू बी 20 गेज एट अ फ्लो रेट ऑफ 60 to 65 ml पर मिनट. ठीक है, पिंक के बाद क्या आएगा? वी हैव द ब्लू कैनुला. Blue is going to be 22 gauge at a flow rate of 35 ml per minute. Then you have the yellow colored cannula. Yellow का size कितना है? It is 24 gauge at a flow rate of 20 ml per minute. And the last one that you have is purple, or we can say violet colored cannula, which is a 26 gauge needle with a flow rate of 12 ml per minute, right? So when we say two large IV cannulas, I should be able to know कि कौन सा कैनुला कौन से कलर कोड में कितना फ्लो रेट हमको देता है. ठीक है, द प्रॉब्लम हियर इज कि आपको कैसे पता चलेगा कि यार इतने सारे कलर्स इतने सारे नंबर से याद कैसे रखें, है ना, याद कैसे रखें. तो उसके लिए एक छोटा सा हमारा निमोनिक है, कलर्ड निमोनिक जो हम बोलते हैं. मान लीजिए कि आपकी जो सॉइल है, द लैंड और द कोर ऑफ द अर्थ इज मेड अप ऑफ लावा. लावा ऑरेंज कलर का होता है. लावा के ऊपर आपको क्या मिलेगा? लावा के ऊपर यू विल फाइंड दैट देयर इज सॉइल. द सॉइल इज गोइंग टू बी ग्रीन कलर. सॉइल के ऊपर क्या मिलेगा? सॉइल के ऊपर यू विल सी दिस ब्यूटीफुल ग्रीन ट्रीज. ग्रीन ट्रीज पे क्या मिलेगा? आपको अच्छे अच्छे पिंक फ्लावर्स मिलेंगे. पिंक फ्लावर्स के ऊपर क्या मिलेगा? नीला नीला आसमान मिलेगा. So this is going to be your blue sky. ये आपका नीला नीला आसमान. आसमान में क्या मिलेगा? What do you get in this nice blue sky? In the blue sky, you have the sun, which is going to be, glowing throughout the day. So you have the sun. It's going to be 24/7. और इसके बियॉन्ड आपको क्या मिलेगा? इसके बियॉन्ड आपको यूनिवर्स मिलेगी. तो यूनिवर्स थोड़ी डार्क कलर होती है. स्काई तो ब्लू है, यूनिवर्स थोड़ी डार्क हो जाएगी. To make you feel that we are talking about universe, इसमें थोड़े से stars डाल देंगे. ठीक है, so this is how you remember the color code of your cannulas. ठीक है, so if you look at the whole component, orange is going to be 14 gauge, soil is 16 gauge, green is 18 gauge, flower is pink 20, sky 22, yellow, sun 24/7, and universe, that is violet, is going to be 26 gauge. ठीक है, so based upon the color code you can remember the flow rate. Remember, flow rates are very 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 important when it comes down to trauma. तो trauma में flow rate के बिना कुछ allowed ही नहीं है. ठीक है, so entire component is important. So you have to remember the color code, the size of the cannula, as well as the flow rate. Okay? Now, when it comes down to trauma, ideally, what is the ideal size of cannula? The ideal size of cannula that you should secure. The ideal size of cannula that you should secure in a trauma resuscitation is 16 gauge. But if you're not able to secure, what is the minimum size of cannula? The minimum size of cannula that you're expected to secure is going to be 18 gauge. Okay? Ideally, you should be able to secure a 16 gauge cannula. If you're not able to secure a 16 gauge cannula, minimum size of the cannula that you should be able to secure in order to resuscitate the patient is going to be an 18 gauge needle. Now, as I say, every day is not a Sunday. What if you're unable to secure an IV line? I told the first step is to secure an IV line, right? Now, imagine that you're trying to secure an IV line and the veins are collapsed, right? if you're unable to secure an IV line? What if you're unable to secure an IV line? Now, if you're unable to secure the IV line and patient do require resuscitation, what will you do? So you have to see that what can you do in an emergency situation, and as a definitive maneuver, what option do we have? Now, in an emergency, what can you do? And as a definitive management, what can be done? Okay. Now, it's an emergency context that you need to get the line as soon as possible so that you can flush. So in an emergency situation, I have two options. I can do an intraosseous needle insertion. I can put a intraosseous needle insertion. I can do an intraosseous needle insertion, or I can perform a venous cut down. A venous cut down is also commonly referred to as venesection. Also commonly referred to as the venesection. Now, intraosseous needle insertion is the needle that you can directly punch into the bone and start resuscitating the patient. Now, if they say what is the usual site, remember most commonly I would put just below tibial tuberosity. I will insert the needle just below the tibial tuberosity and start resuscitating the patient from thereafter. In a venous cut down, what are you going to do? When we say venous cut down, so we usually going to take from the lower limb. Let's say this is the lower limb, this is the calf. This is at the level of the ankle, and let's say this is where you have the medial malleus, right? Right around this, you have a vein that is going to run across this line, and the vein that goes around this is your great saphenous vein. So we say 2 centimeters or 2 finger breadth above the level, 2 finger breadth. If this is the medial malleus, 2 finger breadth above this, you will do a transverse incision. So when you do a transverse incision, you would be able to identify the great saphenous vein. And when you identify the great saphenous vein, I am going to insert the cannula directly from here, right? So this is what we call it as a venous cut down, or also called as venesection, and this is usually performed with great saphenous vein. So vein that is cannulated in a venesection is going to be a great saphenous vein, but preferred one is going to be an intraosseous needle insertion. You take the, it's a quite blunt needle that you have, you palpate the tibial tuberosity, and just below tibial tuberosity you punch it in. You will be able to gain access into the bone and you can resuscitate the patient immediately. But when we say the definitive one, the definitive access for resuscitation is going to be the central line. So we have the entire lecture that is going to be lined up on central lines. So we'll talk about it there in detail. For now, you should know what are the axes that we can take for central line. So when it comes down to axis, I can do an internal jugular vein, I can do an external jugular vein, and I can perform a subclavian vein, right? Out of the three, remember, it is the internal jugular vein which is easy to access and fastest. So hence this is the most commonly used central line. On the other hand, if you want to have a stable fixed line, so the best central line that I can offer to you is going to be a subclavian vein axis. See, internal jugular vein ka jo axis hai, it is going to sit from the neck. It is going to stick out. There's a lot of discomfort for the patient. Every time the patient moves his neck, the line can move. The line, when the line starts moving, it causes the wound, that the entry point will become wider. So wound infection, that is leads to line sepsis. All these are pretty common. Line dislodgement is very common in your internal jugular vein axis. Now to avoid that, you can put your subclavian vein axis, which is going to sit flat onto the chest. The mobility is restricted, greater comfort for the patient, lesser chances of wound infection and line sepsis. Hence, subclavian is going to be considered as best. But again, subclavian should be put, both of them should be put under USG guidance. But if you want to put blindly also by anatomical knowledge, you can put on the internal jugular vein, which is an easier axis when compared to a subclavian vein axis. As simple as that. Yes, you can also take a femoral axis, which is also acceptable. But from a trauma standpoint, these are the lines that you will prefer in the context, right? Yes, when you're trying to put these lines, it can cause injury or breach into the pleura, resulting in pneumothorax. I do agree with that, but then if you do an USG guided one, especially internal jugular, you can avoid the risk for pneumothorax as well, right? Now, the step number 1 was to secure 2 large IV cannulas. That we did. Now, once you've secured the IV cannula, what is our step number 2? So the step number 2, after securing the IV cannula, obviously you did not put the IV cannula to look at it and feel happy about it. You just need to start resuscitating the patient, right? So step number 2 is resuscitation. Now the biggest question here is the resuscitation should be done with. Do you want to do with crystalloids? Do you want to do with colloids? Do you want to do blood transfusion? So a lot of headache that is going to come across it. Blindly, if I talk about resuscitation, in resuscitation, we will be preferring crystalloids. We will be preferring crystalloids. Now the question is, what crystalloid should be preferred for initial resuscitation in trauma, right? Now, when you talk about it, we will not like to use dextrose-rich fluids because of its hyperosmolarity. So I would either prefer Ringer Lactate, normal saline. To be very honest, nobody is going to pin you down if you use Ringer Lactate or normal saline. Both of them are acceptable. But if you have to choose one fluid, now here's the point. You are resuscitating because the patient is going into shock. What is shock? It is a systemic state of low tissue perfusion. Now, what is low tissue perfusion? That is oxygen delivery to the cell is less. Whenever the oxygen delivery to the cell is decreasing or less, the aerobic respiration in the cell will convert into anaerobic respiration. The end product of the aerobic respiration is carbon dioxide and water, which is easily absorbed and it has been excreted out of the body. Water is retained, carbon dioxide is exhaled, no problem at all. But when you talk about the end product of anaerobic respiration, it is lactic acid. Now, as more and more the aerobic converts into anaerobic, more and more amount of lactic acid is going to get concentrated inside the cell. The concentration of lactic acid, when it increases inside the cell, it activates the lysosomal enzymes and it is now going to cause disruption of the cell. Now, when the cells are going to burst open, they are going to cause two things. They excrete the lactic acid into the circulation. Hence, the concentration of lactic acid in the blood will increase and that will result in metabolic acidosis. That's the first problem. Second, obviously, the potassium is also going to excrete into the bloodstream. So, you would expect a hyperkalemia. It will not happen. I'll tell you the reason also why. Now, as the serum, the lactate is being secreted into the blood, the patient is going into metabolic acidosis. Now, the patient is in acidosis. Would you like to give an acidic fluid or an alkaline fluid? It's a very simple context. Now, normal saline's pH is 5.5 to 6.1. RL's pH is 6.5 to 6.9. Both of them are acidic, but RL is less acidic. Another thing is, all you intelligent people are thinking, oh, sir, Ringer lactate has also lactate and lactic acid. But a Ringer lactate they have, not lactic acid. Lactate in the liver goes and converts into bicarbonate. It helps in treating acidosis rather than worsening it. Taking all that into consideration, it is safe to say that the preferred fluid will be Ringer lactate over normal saline, right? It is better to pick Ringer lactate over normal saline because of all these added advantage. What did happen to all that potassium? That is why whenever there is shock, there is low tissue perfusion, obviously the blood supply to the kidneys will also decrease, right? That is how you know, kidneys are getting stressed out or the shock is being there or the circulatory status is getting poor. Whenever the kidneys are hyperperfused, the GFR falls. Whenever the GFR falls, the RAS system kicks in. That is renin, angiotensin, aldosterone system. The aldosterone will start secreting more. What is the function of aldosterone? Absorption of sodium and water, blood pressure maintenance. It acts on the collecting duct and it is responsible for excretion of potassium. All that excessive potassium that is being drained from the cell, it is why the kidney is going to excrete out because of your aldosterone. And that's how the compensation works in the initial phase of shock that you need to understand, right? Now, I did tell you that we are going to use Ringer lactate as the fluid of choice. Now the question is, how much fluid is enough, right? So there is something called as a damage control resuscitation. So when we talk about this concept of damage control resuscitation, it's a beautiful concept. Let's say patient is in shock. There is hypotension with tachycardia. I give 500 ml of fluid, that is Ringer lactate. The parameters are not responding, the patient is not getting stable. Should we give another 500 ml? Okay, let's give. We're given 1 liter. Then also patient is not becoming stable. Shall we give another 1 liter? Let's say, okay, 2 liters. If still not, can we give another one? The point is, where would you stop? As you keep on adding more and more amount of crystalloids, you're only increasing the volume. As you increase the volume, obviously the pressures might become normal, but mind you, all your crystalloids do not have the oxygen carrying capacity. They cannot improve the perfusion. See, the objective of giving fluids in the initial phase of resuscitation is to balance the pressure. It is not to increase, or you're trying to put more oxygen. No, I am trying to give volume. Because of the volume, the pressure will be maintained, and because of the pressure, the organs will be able to perfuse. Because for a blood to reach to every nook and corner of the body, it requires pressure. The pressure is created obviously by the heart contraction, at the same time the volume of the content that is present, because heart contraction also depends upon the circulating volume. Starling forces, no, as the ventricle stretches, the recoil will cause generate pressure, and that generating pressure will pump the blood into your aorta, and from there it is going to go into every nook and corner. So everything depends on volume. To maintain that pressure, I am giving fluids, not to oxygenate. If I have to oxygenate, I have to give blood only, because RBCs have the oxygen carrying capacity, hemoglobin has the oxygen carrying capacity. Your crystalloids do not have oxygen carrying capacity. So don't be in that false pretext that if I give fluid, no, the oxygen delivery will increase. No, pressures will increase. And that is why we need to understand until what point you can give to increase the pressure, and that is what we call it as damage control resuscitation. According to the latest protocol in the damage control resuscitation, the maximum fluid that you can give as a fluid challenge, maximum fluid as fluid challenge. Now what is this fluid challenge? It is to see whether the patient responds or not, is 1 liter. Earlier it was 2 liters. Then we found if you're giving more than 1.5 liters, the response is anyhow poor or the prognosis poor. Now we say 1 liter. You give 1 liter, that is going to be bolus, rapid infusion. See whether the patient responds or not. If the patient is not responding it, that indicates the patient requires additional support. So you have to give other products, which is going to be colloids, and then you have to switch to blood transfusion as well, right? Now when we say damage control resuscitation, now what does the damage control resuscitation basically consist of? According to damage control resuscitation, the first thing, you have to limit the crystalloid infusion. Limit the crystalloid infusion. You cannot literally pump into the patient. The maximum that you're going to give is going to be 1 liter, right? Number 2, it is to anticipate and treat traumatic coagulopathy. It is going to anticipate and treat traumatic coagulopathy. Anticipate and treat traumatic coagulopathy. Next, it is going to be permissive hypotension. Create a permissive hypotension. Now, according to this concept of permissive hypotension, you don't, when you're resuscitating, no, let's say initially systolic blood pressure at 60, 70. I have increased the fluid. As the fluid resuscitation occurs, the pressure is now becoming 80, 90. You don't need to go and get 100, 110 systolic. No. According to the perfusion law, the minimum pressure that is required, especially your CPP, that is the cerebral perfusion pressure, which is calculated as mean arterial pressure minus intracranial pressure, it should be 60 and above. 65 is what we take it. In order to achieve that pressure, 80 millimeters of mercury systolic blood pressure is enough. So permissive hypotension, where a systolic blood pressure target is kept at more than 80 millimeters of mercury, if you achieve this, it is enough, right? You don't need to go and do an over aggressive resuscitation to get extensive pressure. No, this is more than enough. And the last one, if the patient is still not responding, you have to go ahead with damage control surgery. You have to go ahead with damage control surgery, right? So you have to secure the IV line, start the patient on your damage control resuscitation. Initially, you'll resuscitate with fluids. If patient is not responding, you'll move forward. Now, to answer all these problems, I would like to talk about how the blood loss or the volume loss will create more problems. So we'll talk about the classification of the hemorrhagic shock, right? So the basic classification of hemorrhagic shock in this management we'll talk about the classification. It is the classification of hemorrhagic shock. Classification of the hemorrhagic shock. Now talk about the classification of hemorrhagic shock. We can divide them into different classes, right? So we have class 1 hemorrhagic shock, we have class 2 hemorrhagic shock, we have the class 3 hemorrhagic shock, and we have the class 4 hemorrhagic shock, right? Now all the shocks are categorized on the basis of number 1, it is the percentage of blood loss. It is the percentage of blood loss. Next you have heart rate that you're going to look at it, or you can say the pulse rate, heart rate or pulse rate. Then we have something called as the pulse pressure. Pulse pressure is a difference between systolic and the diastolic blood pressure. Then you have the respiratory rate, urine output, the Glasgow Coma Scale, that is your GCS, and how would you like to manage? Management of each particular class. Right. So in terms of hemorrhagic shock, we have divided them into 4 different classes: class 1, class 2, class 3, class 4, and these are the parameters and the criteria for management that we're going to follow. Now, in order to call a patient is having a class 1 hemorrhagic shock, the volume of blood that is lost should be less than 15% of its total volume. If it is 15 to 30%, it is class 2. If it is 30 to 40%, it is class 3. And if it is more than 40%, it is going to be class 4 hemorrhagic shock, right? Now, you'll notice that initially in class 1, the heart rate remains normal, the pulse rate remains normal, the respiratory rate remains normal, the urine output remains normal, the GCS remains normal. So everything is normal. Here you can only give oral fluids for the patient in order to respond. Nothing more is to be done here. When it comes down to class 2 hemorrhagic shock, you would say the heart rate may remain normal or it will start to pick it up. The pulse pressure, or I can say I should add systolic blood pressure. So rather than saying pulse pressure, we'll just replace it with systolic blood pressure, or we can say blood pressure here. We'll add blood pressure rather than pulse pressure. It is more better parameter that your blood pressure, right? So blood pressure in your class 2 hemorrhagic shock remains normal. Your respiratory rate also remains normal. The urine output may remain normal or start to decrease. The GCS will also remain normal. But here, because there is excessive volume loss, I will start the patient on IV fluids. And the IV fluids that I would prefer here is going to be the crystalloids. I'm going to give crystalloids. In class 3 hemorrhagic shock, you will see the heart rate is going to increase for sure. The systolic blood pressure may remain normal as compensation or start to decrease. The respiratory rate will start to pick up. Urine output will become less, that is becoming oliguria. And patient on GCS will start to become confused. Here for resuscitation, I would start the patient initially on IV fluids. But because such a huge volume loss, I cannot only replace it with crystalloids. So here I will use a combination of both crystalloid as well as colloid. But the ratio in which we'll give is going to be 3:1. For every 3 ml of crystalloid, I'll give 1 ml of colloid for compensation. But even if this does not work out, this will require blood transfusion. The possibility of blood transfusion starts from class 3 hemorrhagic shock. It starts from the class 3 hemorrhagic shock. In class 4 hemorrhagic shock, you will see heart rate will pick up more. Systolic blood pressure will definitely fall. Respiratory rate will become high. Here, absence of urine, that is anuria. Patient will become unconscious. And this is where the patient would require massive blood transfusion. Here the patient would require a massive blood transfusion. Now, what is this massive blood transfusion? The basic protocol according to trauma is when more than or equal to 10 units of blood is transfused within 24 hours is what we call it as massive blood transfusion. So whenever you're doing a massive blood transfusion, you cannot give only PRBCs. So you have to make sure that you maintain this standard ratio, that is PRBCs with fresh frozen plasma with platelets in a ratio of 1:1:1. Now, why are you doing this? This is to prevent coagulopathy. If you only give PRBCs, you're not giving other blood products, it can result in coagulopathy. So the reason why I'm giving all these products, that is PRBCs and FFP and platelets all together, this is to prevent coagulopathy. This is basically to prevent coagulopathy, right? So this is the component that you need to remember with respect to hemorrhagic shock, right? So when you talk about hemorrhagic shock, its classification, its management, everything is here. So when a patient comes with a circulatory status which is compromised, secure the IV line, start the patient on IV fluids, and if required, go ahead with colloid as well as blood transfusion. So this on a whole summarizes your circulatory status, right? So now you have a clarity on how or what you're going to achieve by looking at the context. Okay? So when we started the entire discussion in trauma, a quick recap of what we have learned. So we started yesterday by saying that any patient who comes to you with trauma, the first important thing you're going to do triage. It's a color coding system based upon resources available, resources required, outcome as well as the severity of the patient. Then we spoke about something called as trimodal distribution of mortality, where the maximum possibility of mortality is at the time of trauma and next peak comes within 1 hour. So whatever you do in that 1 hour is going to change the outcome. So hence it is called as the golden hour of trauma. Then we spoke about in ATLS, according to the ATLS component, we have primary and secondary survey. The goals are pretty much listed. For primary survey, it is to rule out any immediate life-threatening injuries, whereas secondary survey is to look for every minor as well as potentially life-threatening injuries. Now, how do you go ahead about it? So, in order to control it, we have the ABCDE protocol. So, we have concluded as of today, we have concluded 3 protocols, that is airway, breathing, and circulation, right? So tomorrow when we resume back, we'll be talking about disability limitation as well as exposure and environmental component. We'll talk about the trauma scoring systems as well. Okay. Now in the airway, we spoke about how do you assess whether the airway is normal or compromised. If it is compromised, how do you approach it? How do you secure the airway? What are the methods of securing the airway? What are the immediate methods, that is an emergency? What do you do as a surgical component? Then you have how do you rule out the cervical spine injury. We spoke about the nexus criteria. We told in elaboration that how nexus criteria helps us to rule out the cervical spine injury. And we have the various methods which your anesthetists are quite intrigued about it, about using various methods of intubation in order to secure the airway. Today we spoke about how breathing and ventilation should be assessed. What are you going to look for in terms of immediate life-threatening injuries, which are called as the deadly dozen, the immediate life-threatening, and the potentially life-threatening. You have to look in your primary survey. In the primary survey, we'll be concentrating more on this area so that you will be able to alter the outcome of the patient. Then we spoke about circulation. How do you secure an IV line? How do you get the fluid resuscitation? How do you decide what fluid to choose? How do you categorize it? What is the cannulas color code? Everything we have designed it in a way that is going to help us, treat our patients. Okay? So emergency securing is there. We spoke about venesection. We spoke about central lines. We spoke about resuscitation protocols. And then we did a detailed discussion on classification of hemorrhagic shock and its components, right? So this is it for today. If you have any questions, do feel free to ask, fire it away. So again, as we have decided, as we continue to do series, we'll take a lot of feedback from you guys as well. I want to improve more and more. I'm willing and wishing to contribute a lot to our community in terms of surgical education. So if you want anything else, see all that we have spoken about the ABC protocols. No, I have small snippets and videos also, like how to intubate. I'll show you a video tomorrow. We'll talk about in terms of breathing, ventilation and all that. So each clinical scenarios we have, how does a flail chest looks like, we'll talk about all that. I'll show you those as well. But my biggest component for you to understand is that every single topic that we discuss, it should have a positive outcome. So if you want to contribute anything, if you want to ask anything, feel free to reach out. As you know, if you don't feel like reaching out here, if you want to talk personally, you know where to reach out. It is called as the surgery guy. So this is the Instagram as well as the Telegram channel that we have. It is by my name, that is your Dr. Sandeep Seeram Reddy. So any questions, any queries, do feel to reach out and express any context, any problem you have. Feel free to reach out anytime and anything else. Okay. With that, thank you so much for today. We'll resume back tomorrow again at 9 p.m. We'll do disability limitation. We will talk about the GCS categorization, how do you interpret GCS and all that. And then we'll talk about the expose and examine and the trauma scoring systems. Tomorrow we will finish our primary assessment of trauma, and then we'll start with the secondary assessment in the next week. Right? Until then, thank you so much. Good night. Take care. Bye.